With today's Georgia CTSA Maternal Health Disparities webinar. Our speaker today is Dr. Rachel Bond, and I will introduce her in just a minute. So first I need to let everyone know that this webinar series is eligible for ACME credits. Oops, I don't know why that. The series is, you can get potentially 1 credit for attending the series, and we will send out information on that after the webinar. I also want to let everyone know that none of the planners or presenters have anything to disclose. And now I will introduce Dr. Bond. So Rachel Bond is a board-certified attending cardiologist in Arizona who has devoted her career to the treatment of heart disease through early detection, education, and prevention. She's a women's heart health and prevention specialist and author of several review papers referencing maternal health, sex, and gender differences in cardiovascular conditions that predominantly affect women, along with opinion pieces aimed at addressing health equity, reducing health disparities, and promoting the professional development of women and minorities in the health sciences profession. She has a passion for advocacy of education and mentorship and has advised as an expert source through news and media outlets. Her clinical interests include heart health prevention and maternal health. Dr. Bond is a fellow of the American College of Cardiology, where she most recently has been appointed as a member of the National Diversity and Inclusion Committee, a member of the American Society for Preventive Cardiology, where she sits on the editorial board, a member and co-chair of the Cardiovascular Disease in Women and Children's Committee at the Association of Black Cardiologists, where she is leading efforts surrounding the Black maternal health crisis, and the American Heart Association, where she's a national spokesperson for the Go Red for Women campaign and also sits on the board of directors. Dr. Bond received the coveted Nanette Wenger Award for her work in advocacy in women's heart health, along with being named one of the most influential women in Arizona in 2022. So without further ado, I will turn it over to Dr. Bond.
Oh, thank you so much for that introduction. And as I was saying, thank you for the invitation to present today. We'll get started. So when I was asked to give this presentation, my hope was that we would go through really sound ways to address maternal mortality, but through the scope of cardiovascular care. And as you'll learn through the lecture, there is a very clear intersection between maternal health as well as cardiovascular health, particularly as it pertains to the lifespan approach to how we really should be emphasizing health in general. In terms of our learning objectives today, my goal is to describe the landscape of maternal mortality and morbidity, particularly in the United States, and the role that cardiometabolic health can play on it. Recognize the different life stages and life events that impact maternal morbidity and mortality, including emphasizing some of the contraindications to pregnancy, where patients oftentimes don't have appropriate preconception counseling and inevitably will become pregnant, but how do we best manage those situations in the event pregnancy does occur? And then lastly, individualized strategies to reduce cardiovascular risk. So let's first start with the landscape. Well, the fact of the matter is this is outside the scope of just maternal health. Cardiac disease is the leading cause of death for women in the United States. These are statistics that you may or may not be aware of, but every 80 seconds, cardiovascular disease, a woman dies of cardiovascular disease in the setting of a heart attack and stroke. And we know that heart disease kills more women than all cancers combined. And this is astounding because 80% of heart disease can be prevented, often through lifestyle changes and preventive measures, and then if required, pharmacotherapy as well. So it should come as no surprise that 2 out of 3 women have heart disease, and 1 out of 3 women will unfortunately die from it. And when women actually often think about their greatest threat, many a times it's breast cancer. There's been survey after survey through the American Heart Association that has demonstrated this. And just to put this into perspective, 1 out of 38 women will die from breast cancer, but again, 1 out of 3 will die from heart disease. And when it comes to cardiovascular disease, we know that it is an equal opportunity killer. This graph, which I often like to utilize to kind of pinpoint this salient point, Here we see men in blue, women in red, really demonstrate how the sort of novel approaches to treating cardiovascular disease back in the early 80s were disproportionately being provided to men. That include angioplasty, that included pharmacotherapy with the advent of statins as an example. And as a result, there was a significant dip in the number of deaths from cardiac disease in men. But because those same interventions were not being provided to women, we actually began to see an ongoing rise. And it really wasn't until the year 2000 where we had the first study that largely looked at sex as a specific indicator when it comes to cardiovascular disease risk. That was called the Women's Health Initiative, where they actually tried to utilize the use of hormone therapy to see if it lowered the risk of cardiac disease. And although the study had negative results in the sense that women with hormone therapy actually had higher rates of cardiovascular disease, it was the first time that we acknowledged that we have to have sex-specific study and research. And as a result of that, we began to do that. And here we see a steady decline in the number of deaths from heart disease in women. But what are we seeing in the latter years? That both sexes are actually having mortality trending in the wrong direction. And when you look at the group specifically for women that is most impacted, these are young women of reproductive age, women 35 to 54, particularly women of color who are routinely going unobserved for heart disease. So for me, it sometimes translates very easily into the fact that when we look at the statistics for maternal health, we see that cardiovascular disease is the leading cause of death. And this is particularly in the United States. What I will say is that the CDC has even quoted higher percentages when it comes to cardiovascular disease, close to 30%. And in the US, with heart disease being the leading cause of death during pregnancy, as well as the postpartum, up to 1 year postpartum, the rates often being the highest in women of color, it's important to acknowledge that just like heart disease outside of pregnancy, we know that oftentimes maternal morbidity and mortality is largely preventable 80% of the time. And contributing factors that have led to this heightened rate of morbidity and mortality, yes, has to do with the increased number of first births occurring in older women, as well as the increased prevalence of underlying cardiometabolic risk factors when it comes to the risk factors of heart disease. But also, we have to acknowledge the fact that up to 4% of pregnancies may have cardiovascular complications, despite knowing that there was an issue previously. So oftentimes, these are conditions that are being unmasked. We know that to date, the leading cardiovascular condition encountered during pregnancy is congenital heart disease, which is exciting because through the ability to diagnose these conditions earlier and get appropriate treatment, being endovascular treatment or surgical treatment or close observation, these women are actually surviving and they're becoming of reproductive age where they want to have children of their own. And as a result of that, we're seeing more and more women who have a history of congenital heart disease being reproductive age and wanting to become pregnant. But we also know that heart disease often can be unmasked during pregnancy. And this is what we're going to be contributing a big portion of our conversation regarding was as it pertains to this acquired heart disease. Now, when it comes to cardiovascular disease, it doesn't always preclude pregnancy, but it's important to understand that it could increase the risk to both the mother and the fetus. And as I mentioned in my objective, my goal is really to talk about the different life course and how different stages and different events during each and every stage in a person's life can actually impact their maternal morbidity and mortality, because we know this even in data demonstrating in utero reprogramming, depending on what the fetus has exposure to during the pregnancy of their mother, can actually impact their health later on in life. So I wanted to go through the journey or this journey and journey map when it comes to childhood and adolescence, all the way to that after pregnancy or postpartum experience, to understand the key areas that we could actually hopefully lead to impactful change to lower the statistics. So let's start with health at birth, childhood and adolescence to preconception period. Well, as I said, congenital heart disease is the leading cause of cardiovascular conditions that can actually predispose women to adverse pregnancy outcomes or potentially can impact their pregnancy. Now, when we have someone who has congenital heart disease, it is often recommended that we are having timely counseling on contraception, even beginning during their adolescence and teenage years, with the assumption that sexual activity may precede their wanting or willingness to actually become a mother. As a result of that, these are conversations that should be started by the pediatrician, the pediatric cardiologist, and eventually transitioned over, ensuring that there is that smooth transition from people who have congenital heart disease to an adult cardiologist who will be able to have that ongoing conversation and better risk stratify the patient as well. But then when it comes to childhood and adolescence, we know that there are acquired cardiometabolic risk factors that are on the rise. Even back in February, I was very honored to be quoted in the New York Times for an article, or at least a report that was released at the Society of Maternal Fetal Medicine, where they had demonstrated through this report that children born to mothers with pregnancy complications can face higher heart risk. So these were mothers that actually had a history of either hypertensive disorders of pregnancy or gestational diabetes. And when they actually followed their children up until 12 years of age, they noticed that beginning at the age of 12, they were actually at a higher risk for obesity, diabetes, hypertension, and hyperlipidemia, and that these risks, of course, could translate into future risks if they too decide to have children. So this is a very interesting area because, again, it demonstrates that what happens to us in utero can potentially affect our future cardiovascular health. But outside of what happens to us in utero, we know that there are several cardiometabolic risk factors that are disproportionately affecting children. As an example, childhood obesity, it's an epidemic. 1 in every 3 children and adolescents between the age of 2 to 19 are either obese or overweight. And as a result of that, we need to be making sure that we're optimizing their health. So in the event they decide to have a family when they're older, their health is slightly optimized, because we know that what happens during childhood often translates into the same risk factors that could impact one's future cardiovascular risk. These are just a series of unique risk factors across the life course of a woman that does predispose them to heart disease. A lot of data does support that the earlier you have menarche prior to the age of 10, or the later you have menarche after the age of 15, could be an independent risk factor for future cardiovascular disease. The same way polycystic ovarian syndrome could. Challenges in conception requiring the use of infertility measures, and even having recurrent pregnancy losses, having a multi-gestational pregnancy, and of course, having adverse pregnancy outcomes. But when we hone in on traditional risk factors, so the most common risk factors for heart disease, the ones that cause heart disease oftentimes when optimized to be 80% preventable, the diabetes, the hypertension, the obesity, and the smoking, those disproportionately affect more women than they do men. And so do the adverse pregnancy outcomes, where we know that if someone has exposure to an adverse pregnancy outcome, such as hypertensive disorder of pregnancy, defined as chronic hypertension, gestational hypertension or preeclampsia, gestational diabetes, placental abruption, having a child smaller than gestational age or a miscarriage, or even preterm delivery that's iatrogenic, we know that these can disproportionately affect women's future cardiovascular health, but also their recurrent pregnancies. And this is not insignificant, because 1 out of 5 women encounter these adverse pregnancy outcomes, as they account for about 20% of pregnancies. Now, not only is it important to highlight that those are very unique risk factors for women, but oftentimes those cardiometabolic risk factors disproportionately affect women of color. I was very fortunate to be included in a scientific statement by Circulation, the American Heart Association, that was released in May of last year, where we honed in on the women who were at the greatest risk. And one thing that we knew and was rooted in the fact that we saw these race and ethnic disparities was the fact that 80% of our health is not dictated by our biology, but it has a lot more to do with the social construct, those things called social determinants of health, which are rooted in structural inequities. We know that this is where aspects of the social and physical environment where people have education and their income level, if they have safe spaces for physical activity, and history of maltreatment during childhood, all impact and actually shape their individual likelihood of developing cardiovascular disease. Preventing heart disease deaths in women, both outside of pregnancy and during pregnancy, particularly in women of color, requires us understanding and addressing these upstream factors. And it's for this reason that when I was asked by Dr. Michelle Albert to have an opinion piece that also was released in February of 2023, February of 2022, highlighting the sole reason why we're seeing these high rates, particularly of cardiovascular disease during one's pregnancy as it pertains to women of color, particularly Black women, we wanted to highlight the biology of a term called the superwoman schema. So these are the psychosocial stressors that these women experience due to the history of stereotyping, oppression, the history of disappointment, spiritual values, and form other influences that impact their systemic nervous system, their inflammatory system, and their hypothalamic pituitary axis, all of which leads to increased allostatic load and unfortunately predisposes them to premature cognitive and cardiovascular health. So it's not with any surprise to me that Black women are 3 times to 4 times more likely to die from pregnancy-related causes because of these psychosocial stressors. And when we actually hone in, not just per se on Black women, but women as a whole, we know that when it comes to cardiometabolic risk factors, oftentimes people are going into their pregnancies with a large number of them. Actually, data has demonstrated unfavorable cardiovascular health, which is defined as having at least one of these traditional risk factors, is actually very prevalent, where favorable health is noted in fewer than 1% of people of reproductive age, both men as well as women. And we know that unfavorable pre-pregnancy cardiovascular health is associated with increased risk for those adverse pregnancy outcomes. And this is concerning because when it comes to preconception counseling, we know that it's scarce. 45% of pregnancies are unintended, so it becomes very challenging to optimize this unless we think about health across that life course. Every time we capture these women in childhood and adolescence and early adulthood, we need to talk about these traditional risk factors. We need to talk about their risks and, more importantly, how we can best optimize it. And when it comes to Black women, they have some of the highest adjusted rates and prevalence of unfavorable pre-pregnancy cardiovascular health. So as a result, again, it comes as no surprise that they're going to have the greatest risk for these adverse pregnancy outcomes. And this is where preconception counseling is so important. And when we think about cardiac disease, in general, preconception counseling is always advised, but it's also advisable for people who have high cardiometabolic risk factors. This is where we have the ability to provide an accurate prognosis as possible for the mother, the baby, giving accounts of potential hazards. We also talk about the risk to the family. We also talk about whether risk will change with time or management. We also often recommend risk stratification, which I'll get into, where that should really help to organize antepartum care. It will outline principles and cardiovascular follow-up and plans. This is a time where we would talk about medication adjustments if they're on any teratogenic medications, transitioning to medications that can often be used during pregnancy. And this is also where we come up with the idea if they would be recommended for pharmacotherapy based on their risk. As an example, lots of studies demonstrate the utilization of low-dose aspirin to decrease the risk of preeclampsia, preferably between 12 to 28 weeks gestation, but best before 16 weeks gestation in certain patient populations is recommended. This is when those conversations should be happening. And this is where we also will be talking about optimizing cardiovascular health. If their cardiovascular risk is deemed high or prohibitive, this is where alternative options are addressed, such as adoption, surrogacy, contraception options. And then this is where that really the introduction to the maternal heart team is suggested. So what is the maternal heart team? Well, it's a team led by clinicians from cardiology, maternal fetal medicine, obstetrics, sometimes anesthesia, pharmacy, and of course, nursing. And their goal is to individually talk about the patient from a situational perspective, understanding what their risks are. We know that women who have moderate or high risk complications during pregnancy, which we'll get into what that entails, are absolutely suggested to be part of the maternal heart team, but we also know that more recently we're suggesting that those who are at high risk for complications due to high cardiometabolic risk also should have a maternal heart team approach where we can lower the likelihood of having complications, not just during the pregnancy, but also up to that 1 year postpartum. And when we think about during the preconception visit, how we define maternal risk, there's a series of calculations that we can use. We know that the risk of cardiac complications can be estimated just by taking a detailed history, doing an exam, sometimes doing imaging, which I'll get to. But really, we use a series of these risk estimates. And the most commonly used one is the CARPREG-2, along with the modified WHO. And that's the best way to risk stratify patients. And when we think about the CARPREG-2, it includes a series of predictors. And we know that the more points they acquire, the higher their risk of having a primary cardiac event. This includes a prior cardiac event or arrhythmia. If they're going into the pregnancy with New York Heart Association class 3 to 4 symptoms or evidence of cyanosis, potentially Eisenmenger's disease, mechanical valves, ventricular dysfunction, they have high-risk left-sided valve disease, if they have pulmonary hypertension, coronary artery disease, high-risk aortopathies, or any prior cardiac intervention, as well as late pregnancy assessment. And data demonstrates that all you really need is to have one of these to have a risk of 5%. But oftentimes we see that when the risk is above 1, it's not insignificant. This could be a risk of having a cardiac event anywhere from 10 to 41%. And then we have the modified maternal WHO risk classification. A perfect world would be taking care of women who fall in the group 1, where their risk is not significantly increased. It's about 2.5 to 5%. This includes mothers who have those cardiometabolic risk factors that I mentioned, the hypertension, the diabetes, the obesity going into the pregnancy, but this also includes the repaired simple lesions, such as an ASD or VSD, or an uncomplicated valvular condition, or ectopic atrial and ventricular beats. But then once we get to the modified WHO2 and the modified WHO2-3, we know that the risk becomes intermediate. And this again includes some of these defects, but unfortunately not operated on, potentially diagnosed during their pregnancy, as well as mechanical valve. And I find it interesting that mechanical valves are only classified as modified WHO, because the complexity of how to manage these women with mechanical valves oftentimes, of course, doesn't make it prohibitive to have a pregnancy, but it's definitely a conversation where we have to weigh fetal loss versus mothers having a thromboembolic event. So it does require a lot of planning, a lot of management, and this is where the referral to a maternal heart team is important. But then as we get closer to the right, we see that these are the situations where the risk of having a pregnancy would actually be very, very high, and thus it would be suggested to be prohibitive. And we'll delve into that in a little bit. But when we're risk assessing these patients during their preconception, there's a lot of things that go into it from a cardiovascular perspective. At a minimum, we're doing an electrocardiogram to see what their baseline electrical function looks like. We're also looking at those laboratory tests that screen for those cardiometabolic risks, like the diabetes, the high cholesterol, also any underlying thyroid condition. And in certain cases, we're checking a baseline beta natriuretic peptide. We know that the beta natriuretic peptide is a neurohormonal biomarker that specifically allows us to see if there's overstretching of the heart. It's a wonderful indicator often for patients who are going into the pregnancies with a prior history of cardiomyopathy, even sometimes in the setting of preeclampsia. And oftentimes I actually do check it during that preconception visit, just so we have a baseline and periodically rechecking it throughout the antepartum. Preconception imaging is also important. This is where an echocardiogram is often recommended. And if a patient has evidence of aortic pathology, a CT and MRI would be suggested as well. And this is important for identifying those high-risk lesions, which we'll get into. Referral to a geneticist may be suggested, and sometimes also preconception exercise testing is suggested as well. I will say that this is mostly considered for risk stratification for women who have congenital or valvular conditions. We also utilize it sometimes for women who have had a prior history of ventricular cardiovascular dysfunction. More recently, although there's no guidance on this, we can also consider it for moms who have high risk cardiometabolic risk factors, because we get a lot of information with the stress test. When we do a treadmill stress test, we're looking to see, is there exercise-induced hypertension? What we're also looking for is actually seeing what their exercise capacity is. If they're able to reach a capacity greater than 80%, that's favorable. The same way, if we're able to reach a peak heart rate above 150 beats per minute, that's favorable as well. We're looking to see if we're able to induce any arrhythmias and if there's evidence of myocardial reserve or inducible ischemia. So there's a lot that we can actually achieve by doing these cardiac stress tests. And one thing that's important is that this pre-pregnancy counseling, yes, it's strongly advised, but as I made mention of, oftentimes these are women that have unintended pregnancies. So we have to make sure that at every period and every stage in their reproductive health journey, we're asking the question, would you like to become pregnant in the next year? So we're thinking about suggesting some of these testing. We're thinking about, at a minimum, checking their blood work to optimize their health. So in the event they do decide to have a family or accidentally become pregnant, their health is optimized. So now let's journey through the antepartum and intrapartum, because the issue with pregnancy and heart disease, and these are women who have known cardiovascular disease, is that symptoms and signs of a normal pregnancy can actually be very confusing, and it could definitely suggest the presence of cardiac disease. But because the symptoms and signs are often very similar, it could also make it very problematic to diagnose underlying cardiac conditions. So shortness of breath, swelling in the legs, feeling a little bit of exertional dyspnea, or feeling winded when you're doing activity. But the other problem is that pregnancy could exacerbate and unmask pre-existing cardiac disease. Cardiac disease can also manifest for the first time in pregnancy, and we know that maternal cardiac disease can increase fetal risk as well. Here are some of the mistakes when we think about heart disease in pregnancy. Failure to recognize that a mother and birthing person has cardiac disease is also a major risk, because as I noted in the problem, a lot of the symptoms and signs of heart disease in women are the same symptoms and signs of pregnancy. So oftentimes it can be very hard to differentiate. We also know that maternal cardiac disease leads to often inadequate pre-pregnancy evaluation, as I mentioned. And when we know a mother has maternal cardiac disease, the management for it can be very complex. So there's really not an ideal management pathway. We are really trying to hone in on those critical stages of pregnancy, especially in women who have underlying heart disease, because we know that these are when the changes often occur the greatest. And changes in terms of hemodynamics can start as early as 5 to 6 weeks gestation. We know that they usually have the maximum amount of changes around 30 to 32 weeks gestation. The intrapartum period also leads to some of the highest hemodynamic changes, the period just after delivery, and then the second week of the puerperium absolutely can also lead to changes. And these changes are highlighted very nicely in this graph, where we begin to see, even within the first trimester, that the cardiac output can increase. Oftentimes, when we get to the third trimester and during that laboring or intrapartum period, that's when it's at its peak. And that could be anywhere between 40% higher than the standard, even up to 80% higher than the standard. And oftentimes we also see that because there's a drop in systemic vascular resistance, with that drop in the first and second trimester, there could also be a drop in blood pressure. But reflexively, as a result, to maintain cardiac output, there's an increase in heart rate. And when we think about heart rate, particularly as it gets closer to that third trimester and during that laboring period, we know that sometimes the heart rate can increase up to 20% from their baseline. Once the delivery is done, this is sort of where there's normalization in that early postpartum to late postpartum, even up to 6 months it can take to kind of go back to those standard hemodynamics. So understanding this physiology is extraordinarily important, because the other things that change are volume. When we think about volume, we know that there is an intravascular volume increase of 50%. And this is in proportion to the plasma volume, but not in proportion to the red blood cells. So this is why very commonly we see anemia of pregnancy, because the red blood cells don't increase to the degree that the total blood volume and plasma volume increase. But what do we also see? As I made mention, that cardiac output increases even more than 40% at delivery. So a lot of times with this peripheral resistance that drops as a result of the fact that we need to increase uterine blood flow, blood volume increases by 40 to 45%, heart rate increases by 10 to 20%, leading to that cardiac output. We also see that drop in blood pressure, and oftentimes we see that venous pressure in the lower extremities increase. And this is why about 80% of women have evidence of peripheral edema during their pregnancy. But why is this important? Because by the time these mothers reach the 32nd week gestation, maternal cardiac output could be at its highest. And we know that during delivery, and as I mentioned already, with the increase in heart rate and blood pressure, this cardiac output could increase to even about 80% above the pre-pregnancy level. And this is why pregnancy is oftentimes considered a woman's first cardiac stress test. As noted, if they have underlying heart disease in the pre-pregnancy period, oftentimes it is recommended that we perform a stress test on them because we want to mimic what could potentially happen during their pregnancy and make sure that they pass their stress test with flying colors. But because of the hemodynamic changes seen during the pregnancy, it should come as no surprise that regurgitant lesions that are very dynamic are oftentimes much better tolerated than stenotic valvular lesions that have often a fixed finding. And this is why when we look at the pregnancy risk WHO4, where pregnancy is contraindicated, what's listed on it are those stenotic lesions, severe mitral stenosis, severe symptomatic aortic stenosis, even pulmonary hypertension. And I want to highlight the fact that when it comes to pulmonary hypertension, we know that even often what they have suggested is any mother who has a history of pulmonary hypertension is at increased risk of having poor cardiovascular outcomes. I'm often asked, well, if their pulmonary hypertension is mild, is at the same risk as if it's severe? And we know that data does support that the higher the severity, the higher the risk. Typically, the cutoff being a right ventricular systolic pressure above 49 millimeters of mercury. But in this situation, this is where we want to figure out the underlying cause of the pulmonary hypertension, and more importantly, optimize their overall health by ensuring that we are putting them on appropriate pharmacotherapy if necessary, and treating the underlying cause if it's left-sided heart disease due to a cardiomyopathy or a valvular condition, or if it has to do with a intrapulmonary issue, making sure that that's optimized before having that conversation about what their true risk would look like in the event they wanted to have a child. But also included in the pregnancy risk WHO4 are the aortopathies. And we know that many of these aortopathies can lead to notable evidence of rupture. Probably the least likely is bicuspid aortic valves, but we are very hesitant to actually proceed by giving recommendations of having a safe delivery without, again, intervening on the valve and or the aorta for women who have an aorta that's greater than 50 millimeters or 5 centimeters in greatest diameter. We also see this with native severe coarctation, as well as type 4 Ehlers-Danlos syndrome, which can impact about 5% of pregnancies, but those women are at the greatest risks of having rupture. Largely because of their impairment in the collagen in that aortic wall. So these are the women of highest risk where we would be recommending to delay pregnancy until we could optimize their underlying conditions. And most importantly, this is where, in the event these women were to become pregnant, but really any woman who has heart disease, a delivery plan should be made. And this plan is best made between 20 to 30 weeks gestation. Number one, this plan must be recorded in the medical record. This is where we outline the timing, location, and mode of delivery, and also talk about the use of regional anesthesia. This is where we identify if cardiac monitoring is needed in the form of a telemetry unit or potentially even invasive lines. And this is where the discussion on induction of labor would be considered if the mother goes to 39 to 40 weeks gestation. All women with cardiac disease are typically suggested for induction of labor at 39 to 40 weeks gestation. Vaginal delivery is always favored. You know, C-section is generally reserved for obstetric indications, and there are situations, which I'll get to, where C-section may be favored, but there's also consideration for assisted second stage where you use vacuums or forceps, and this could be considered for prolonged second stage for preload dependent lesions. So those are often our valvular conditions, our aortopathies, if they have a Fontan circulation or pulmonary hypertension. We also know that cesarean delivery is favored if there is preterm labor and a person is already on an oral anticoagulant due to the fact they have a mechanical valve, as an example, if they have aggressive aortopathies, acute intractable heart failure, those critical left-sided valvular diseases that were not optimized and managed before delivery, and the severest forms of pulmonary hypertension, including Eisenmenger syndrome, where they have evidence of right-sided heart failure. But once these mothers actually become pregnant and deliver, this is where it's important to understand in the postpartum, those key points in postpartum where we're following them and keeping an eye on them. So immediate postpartum, the suggestion is that they're being monitored at a minimum for 48 hours. Women who have high risk cardiac conditions actually should be monitored at a minimum for 72 hours or more in the hospital on cardiac telemetry. We also know that this is where we have an opportunity to talk about medications that are safe with lactation, assess and treat cardiac complications, and counsel patients on symptoms, as well as counsel them on possible complications that they should be looking out for. During the fourth trimester, it's really important that these patients are being seen within 3 to 7 days of follow-up after discharge, that they're having a comprehensive evaluation within 6 weeks, including mental health screening. We know that many of these women are at the highest risks of postpartum anxiety, postpartum depression, that are probably second to cardiovascular disease, one of the most common causes of maternal mortality as well. And we also know that this is an opportunity to talk about contraception counseling. But then there's the long-term postpartum. Again, knowing that up to 1 year after delivery, these women should be checked very closely, where there's a transition of care for closer and ongoing assessment, interconception optimization, or post-childbearing care. And this is an opportunity where if someone actually had an adverse pregnancy outcome, cardiometabolic risks should be actually screened for. So these risk factors should be screened within 3 months postpartum. And if abnormal, they should be rechecked 6 to 12 months postpartum after implementation of appropriate lifestyle intervention. So the postpartum period gives us an opportunity to really optimize care. And this is so important because when we look at maternal mortality, we see that 53% of mothers died between 7 days and 1 year after giving birth. And consideration should be made to have a heightened suspicion for conditions like cardiomyopathy, particularly peripartum cardiomyopathy, because it could represent 45% of all of these pregnancy-related deaths between 6 weeks and a year postpartum. And it's for that reason that I want to hone in on peripartum cardiomyopathy, knowing that a previous history of peripartum cardiomyopathy with residual left ventricular function is actually deemed a contraindication. And often we are suggesting that these women do not partake in a future pregnancy. So what is peripartum cardiomyopathy? Well, it's a diagnosis of exclusion where women present with heart failure in the last month of pregnancy or up to 5 months postpartum due to left ventricular systolic dysfunction with an EF less than 45%. This is where, when we think about diagnosis of exclusion, we're ruling out the more common causes of cardiomyopathy. The most common cause in the United States is ischemic heart disease. And this is where we have an opportunity to look at the coronary arteries to rule out any blockages. We also want to make sure that there wasn't a viral component to this, that it wasn't due to a hypertensive disorder of pregnancy or an arrhythmia. And then obviously that the timeline falls within that last month of pregnancy or up to 5 months postpartum. What is the cause of peripartum cardiomyopathy? Well, the exact cause remains unclear. We know that it's believed to be the result from a combination of genetics, socioeconomic factors, hormonal and immune factors. We know that the prevalence, although rare, is really largely dependent on the region. So as an example, we have about 1 in 1,000 to 1 in 4,000 pregnancies in the United States, but in countries like Nigeria, it's about 1 in 100, and countries like Haiti, where there's a disproportionate prevalence of it, it's about 1 in 300. And research suggests that women of African descent may be at higher risk of developing peripartum cardiomyopathy compared to other racial groups. So as a result, Black race is a risk factor. And I do want to highlight the fact that this is most probably also a social construct instead of a biologic or genetic. We also know that women over the age of 30 can have a heightened risk if you have a multi-parity pregnancy, if you're coming into the pregnancy with pre-existing heart conditions, especially hypertensive disorders of pregnancy like preeclampsia, and very rarely there could be a genetic predisposition. The timing of diagnosis is important because the majority of women with peripartum cardiomyopathy are diagnosed after delivery, and it's typically within the first month postpartum. For us in my healthcare system, we actually decided not just for peripartum cardiomyopathy, but understanding that heart disease is the greatest threat for these women, especially in the postpartum. We gave some insight to our emergency room physicians by using the California Maternal Quality Care Collaborative. And in California, they created this collaborative back in 2006 to actually hone in on protocols that can help diagnose cardiac disease better in women that are presenting to the emergency room or the L&D unit. And what they were able to do, knowing that peripartum cardiomyopathy, like many heart conditions, can mimic the normal findings of late pregnancy and the peripartum period, they wanted to educate about the red flags to look out for. So this is shortness of breath at rest, severe orthopnea, abnormal hemodynamics, where you have a resting pulse rate greater than 120 beats per minute, a resting systolic blood pressure that could be elevated, and of course, oxygen saturations that are very low. And if they fell into any of these red flag categories, this led to a prompt evaluation by, depending on the stage of their maternal journey, a MFM, a primary obstetrician, a hospitalist, and of course, a cardiologist. So what we have done in my healthcare system is first have the emergency room ask the question if they are or have been pregnant within the past year. And if they have, again, asking when your last pregnancy was, thinking about this California Maternal Quality Care Collaborative, because it could really be the difference in not missing the diagnosis, because oftentimes women with peripartum cardiomyopathy could have a delayed diagnosis because, again, a lot of the signs and symptoms can mimic that of what you see in late pregnancy or the peripartum period, especially if they are presenting without those red flag symptoms. So those more subtle symptoms of dyspnea, maybe a little pressure in the chest, maybe a little swelling in the leg. And if you fall again into a situation, especially if a mother has risk factors, particularly if there's abnormalities on the physical exam, we are suggesting following this sort of algorithm by doing additional testing. And this is where performing an EKG and then re-engaging a beta natriuretic peptide can oftentimes make a difference, because again, that could help us to clench the diagnosis much earlier, so we lose the opportunity for those delayed diagnoses. And when it comes to prognostic factors, we know that mortality estimates differ significantly based on racial group, geographical region, and duration of follow-up when it comes to peripartum cardiomyopathy. As an example, at 1 year follow-up, mortality rates in the US range from 4%, but also it could be as high as 11% in a study where 96% of those participating were African-American women. We know that the 2-year mortality rates have been reported anywhere from 0 to 16% in different studies in the United States, with higher mortalities in Haiti as well as Africa. And less data is available about the long-term outcomes greater than 5 years, but the US mortality estimates have ranged anywhere from 7 to 20%. I think of most relevance, as I mentioned before, is that 45% of all pregnancy-related deaths occur because of peripartum cardiomyopathy, and it's largely between that 6-week and 1 year postpartum. And when it comes to women, once they are adequately diagnosed, hopefully early on in their course, recovery for the most part is favorable. On average, about 54% of women do have recovery in their ejection fraction, which the way we define that is an EF greater than 50%. And peripartum cardiomyopathy is associated with greater rates of recovery than any other form of heart failure with reduced ejection fraction. It typically occurs within the first 3 to 6 months, but it could actually take even up to 2 years following diagnosis. And when we think about how we're treating these women. We still need studies out there to help determine what is the best way. I am very fortunate because I sit on the advisory for the peripartum cardiomyopathy registry, where we're encouraging people who have patients that have peripartum cardiomyopathy to sign up for the registry, where we can follow them and see what medications were provided. When it comes to medications, this is where shared decision-making is so important, because discussions on lactation are needed to occur. If we, after weighing the risks and benefits with the patient, feel that the patient desires lactation, then we should encourage them to proceed with lactation and place them on lactation-safe guideline-directed medical therapy. And if you look at this chart when it comes to heart failure, there are several. If after closely monitoring the clinical progression with the suggestion that we repeat cardiac imaging in the form of an echocardiogram, usually within 4 weeks, if we see that there's no improvement in the EF, this is where readdressing lactation would be of significance, because this is where we talk about the 4 pillars of heart failure therapy. So those guideline-directed medical therapy that we know leads to the best outcomes when it comes to heart failure with reduced ejection fraction. This includes beta blockers, which are safe to use both during pregnancy as well as during lactation. This also includes our sacubitril valsartan, which really there's no information to see the safety when it comes to lactation. As a result of that, it's not advised. This is also where aldosterone receptor agonists, as well as the SGLT2 inhibitors, which are, again, not well studied when it comes to lactation and during pregnancy. But what they have noted is that SGLT2 inhibitors can cause dilatation of the renal pelvis, congenital anomalies, and it could increase miscarriage rates. So it's advised to defer these pillars of guideline-directed medical therapy, both in pregnancy and during lactation. But this, again, is where that shared decision-making is going to be important. And our hope is that with this registry, we'll be able to determine what's the best course of pharmacotherapy and, more importantly, management for these patients. And why is this relevant? Because we know that the sooner we put them on the appropriate guideline-directed medical therapies, in terms of outcomes, it could be favorable, but there are situations that may lead to limited recovery. This includes women who may have gone into the, who may have had a echocardiogram that demonstrated that they had a lower than ideal left ventricular ejection fraction, less than 30%. They have a 6-fold risk of having persistently low ejection fractions. This also could be seen if their EF remains persistently decreased after 2 months, if their left ventricular sizing is dilated, if they have New York Heart Association class 3 or 4 symptoms, if they have a thrombus. And I will say that there's some data to suggest for women who have an EF less than 30%, the utilization of anticoagulation, particularly knowing that pregnancy could be a hypercoagulable state, even that very immediate postpartum period could be a hypercoagulable state, is often advised. We also know that situations that could lead to limited recovery is Black race, being a social construct, obesity, if they have elevated cardiac biomarkers, and most importantly, if they have delayed diagnoses. This is why, again, we have to have a very high clinical suspicion and have tools in place in our health system where we can hopefully diagnose this condition as soon as possible. Long-term outcomes. So after recovery, optimal duration of guideline-directed medical therapy is unknown. Many people right now are suggesting that when you gradually, or what we should be doing is you should gradually watch and closely discontinue medications in a step-by-step approach with some protocols every 3 to 6 months. We also want to make sure that we are continuing to surveillance these patients after recovery. And if their EF didn't recover, typically, as cardiologists, we wait about 3 months to reassess. And if their EF is still low, we suggest the initiation of an ICD for primary prevention in the event, knowing that they're at higher risk of ventricular arrhythmias. In this situation, knowing that there could be a delay in recovery up to even sometimes 2 years, people are suggesting holding off on ICDs, and this is where the consideration for wearable defibrillators in the form of a life vest may be considered. But again, This is why conversations with cardiologists is so important. Now, when it comes to subsequent pregnancies, this is, I think, a really important topic of discussion because we know that EF does matter and the normalization of EF matters as well. Women with a history of peripartum cardiomyopathy who have persistent left ventricular dysfunction, which is an EF less than 50%, are recommended to avoid future pregnancies due to risk of heart failure. And we know that this is, again, why they fall in that prohibitive class. Now, in the event recovery occurred, these women would be closely followed, preferably before conception. They would be followed at the end of every trimester. And the way we would be following them is by repeating an echocardiogram, checking their beta natriuretic peptide, continuing with that method 1 month prior to delivery, doing it again after delivery prior to discharge from the hospital, and then doing it again 1 month after delivery, at which point conversations would be as to what that kind of routine surveillance would look like thereafter. So I think it's important to highlight that when women have had a history of peripartum cardiomyopathy, if they've had recovery, they can absolutely become pregnant again. They require really close observation. And this is where, particularly if these women that have cardiac disease also on top of it have adverse pregnancy outcomes, it's important to also educate them during their pregnancy of what this means for their future cardiovascular risk, because pregnancy can be a window to one's future cardiovascular health. And when we think about adverse pregnancy outcomes like the ones I mentioned, we know that these can actually increase one's risk of cardiovascular disease, not just in the form of ischemic heart disease and stroke, but now data is actually even demonstrating that preeclampsia, gestational hypertension, gestational diabetes, preterm birth, and small for gestational age can actually increase their risk of heart failure as well as valvular conditions in the future. And this is up to 20 years after they delivered. And this is a 2 to 4-fold increase depending on the cardiovascular condition. So it's really important that we're screening for these adverse pregnancy outcomes by taking a detailed history, but more importantly, making sure that we're transitioning these patients into the hands of at least a primary care doctor who can determine thereafter if they should see a cardiologist. I wanted to briefly highlight what we are doing in my healthcare system. As I mentioned, we are really utilizing the California Maternal Quality Care Collaborative. One thing that we noted is, although California was able to decrease their maternal mortality rates by 65%, despite this, the people that had the highest risks of morbidity and mortality, such as the Black and Indigenous population, experienced 3 to 6 times the rate of maternal mortality still. So even though these are in place, the outcomes still demonstrate that these women are having the highest rates. And what this told me is that our focus can't just be at the hospital level. We have to think about going to the ambulatory setting and meeting these women where they are actually going and receiving their care. So this is where we created a passport that talks about a lot of the signs and symptoms to look out for, to educate them on what preeclampsia looks like, educate them on underlying cardiac conditions. And this is where we partner locally with the American Heart Association to really hone in on blood pressure control, preconception, as well as postpartum. And then this is where we really have talked about the importance of interconception care. So optimizing health in between pregnancies, because I think this approach is actually going to lead to improved outcomes. So in conclusion, there are rising incidences of heart disease during pregnancy. Yes, a delivery plan should be made between 20 to 30 weeks gestation. Counseling, though, these patients on management if they have underlying heart disease should begin preferably before conception, but understanding that oftentimes these patients have unintended pregnancies, it makes it a little challenging. All diseases are not created equal, so evaluation of maternal risk is key. And there is limited data on most conditions, but this is where utilizing the maternal heart team is going to be impactful, where you have that co-management and really thinking about health across the life course, I believe is going to truly make that difference. So thank you so much for the opportunity. I look forward to answering any questions that you have.
Thank you so much, Dr. Bond. I wanted to go ahead and open the floor for questions. You could put it in the chat or unmute and ask your question.
Hey, it's Jane Ellis at Grady Hospital in Atlanta. Thank you for an excellent presentation. I really enjoyed that. I'm an MFM here at Grady. And just a question for you. It may sound like a criticism, but it's not. But I know in working with some of my cardiology colleagues, they are sometimes sort of not overwhelmed, but puzzled by some of the physiologic changes that are encountered in pregnancy and how that might impact cardiac disease and so forth. So I'm just wondering, with what we now know about the role of cardiac disease and maternal deaths, do you see any of the fellowships moving toward incorporating pregnant women or training in pregnancy into those fellowships? Because I think it would certainly be valuable. Thank you.
Yes, thank you for your comments and your questions. So because of that, and because of the fact that cardiac disease is the leading cause of maternal mortality as well as morbidity, we actually have made significant changes to our cardiology fellowship curriculum. I will say that probably the greatest driver has been the American College of Cardiology. They have a cardio obstetrics course that really is honing in on helping program directors better prepare their cardiology fellows for the world of taking care of women. And during a woman's life course, they're most probably going to have exposure to their reproductive years and pregnancy. So we have really been aware of the fact that we have to revamp the cardiology fellowship. One other area that we are revamping is honing in on making sure that our fellows are very aware and attuned to those social determinants of health as well. Because when it comes to the women that are dying at the highest rates, as I demonstrated, it's the Black and Brown community, particularly Black women. As a result of that, not only are we focusing and revamping our education on pregnancy and making sure that they're aware of the importance of not just caring for these women during their pregnancy, but also asking those pertinent questions if they had any adverse pregnancy complications. So that way they understand the true risk that the person may have when it comes to their future cardiovascular risk, but also honing in on those social aspects that can place them at a higher risk as well. And this is where doing implicit bias training and cultural competency education is also something that the cardiology fellowships are more attuned to. So I'm very excited for the future because I think that this education is going to hopefully and preferably lead to better outcomes, at least in terms of that collaboration between the OB, MFM, and cardiology world.
Thank you. I appreciate that response.
Any other questions?
Yes, Dr. Bond, this is Dr. Bond DeWare. I'm with Morehouse Healthcare, OBGYN, and wonderful presentation, wonderful bringing out the implicit biases and social determinants and those that do cardiology and OB and do it well. And but I have a hard time, and I don't know if there are any protocols in place for, and I call it our patients that we're taking care of, in terms of getting them in to be seen, baseline echoes, those sorts of things, preventative things, right? So that, we're not calling at the last minute when everything's caving in and crashing and, and we need this ultrastat, consult, or we need care postpartum. That's where I sort of am trying to get more on the preventative side for patients, for cardiologists, for myself. And I just don't see those protocols in place because we've known about this for quite some time.
Exactly. And often what I encourage is that as long as you have at least one champion, and I saw Model A on the call earlier, so I know she's a big champion of this because her and I work very closely together at ABC and ACC. But as long as you have that one champion, it's a lot of pressure on that one champion, but this is where the education of that one champion is key. Because when I first started in my health system, I sort of had the same conversations with the OBGYNs that, cardiology often is very resistant to doing these baseline echoes, or sometimes they're questioning the reason behind it. And this is, again, where we have to provide that education and, more importantly, ensure that they are aware that if they need someone to co-manage these patients with, they have access to that cardio-obstetrics expert. I would encourage that these are conversations that are happening on a monthly basis. One thing that has been very beneficial in my health system is we created a maternal heart council where, as I kind of demonstrated in that diagram, we talk about each of the different areas, the inpatient care, the ambulatory care, the preconception, the postpartum care, but it's really to create guidances so people are more comfortable in caring for these particular patients. And again, understanding that if they're not, it's a co-managing relationship. There are often times where I have had cardiologists that have asked me to take over the care during the antepartum. And then in the postpartum, maybe not immediate postpartum, but after that 1 year postpartum, I'm referring them back to the cardiologist, right? So it's a matter of creating those systems in place. And I wish that there was a more formalized approach at a national level that made it easier for us to have it more standardized. But the challenge with that also is that we all have different patient demographics and patient populations. So I do think it's a unique opportunity for each health system to kind of perfect it and make it special for their individual health system. But having that champion to provide that education to cardiology, I do believe is going to go a long way.
Okay, thank you so much. And, you know, I was in Florida and they had that same thing sort of postpartum where there was this fast track to in a collaborative effort to get patients into cardiologists, and it worked wonderful. So I'm hoping that you're right, that someday we can get that sort of here.
Yeah, and I'm just reading in the chat that Jane Ellis said that they are working towards getting a cardiac referral statewide network set up for our patients and postpartum women in Georgia. Yeah. And that's through the Georgia ACC and Medical Association of Georgia, which is wonderful.
Yes, perfect. Yeah. Thank you.
More to come on that. Thanks.
Yeah, that's exciting. I'd love to see how you guys are planning on doing that. That's amazing.
We're gonna make it work.
Exactly. You'll pilot it, hopefully, for the other states.
Hi.
Hello.
Hello. I'm sorry I was in and out because I'm on call and I listened to quite a good chunk of your presentation. Thank you very much for doing this. I just have a question about practice that a method of practice that I carry out when I have patients, because I've noticed that a lot of the patients that have undiagnosed cardiac disease are usually in their late 30s or early 40s. So my practice now is that if I have a patient who is 38 years or older who has not had an EKG in the last 2 years, what I usually do, I send them for a baseline EKG. If there's a problem with the EKG, then I ask to do an echo and get a cardiology evaluation. I've had some of my partners think it's an overkill, but I just think based on your lecture today confirms my suspicion that the way women don't present the classic way, the way men present. I mean, I have an old lecturer who would say, when a man has a cardiac disease, even a squirrel can look at him and be like, yeah, you need to go to the hospital. When a woman has a cardiac condition, we are always finding reasons why she doesn't have a cardiac condition. So, and again, in a situation whereby we have our Black and brown patients who do not actually see a doctor until they are pregnant, I think for me, it's a way of quick screen to make sure if they are 38 years or older, especially when they are 40 years or older, I always order a baseline EKG. I mean, since we do this for patients who we are going to take to the OR anyway, wonder why we can't do that for baseline. But I just want to know your take on that.
Absolutely. So one thing that's important to highlight is that women are having, as we all know, children later on in life. So 40 is obviously a time sometimes people are having children for the first time. There's no guidance currently. How should we be risk stratifying them? But it's highly, highly encouraged and recommended that if they have, because that would fall under a high cardiometabolic risk factor, that they are at a minimum getting an electrocardiogram. And again, because there's no guidance, oftentimes there's a question about, should we be also doing other imaging like an echocardiogram, an exercise treadmill stress test? And I think that if their risk, one being age, is coupled with additional cardiometabolic risk factors, the long and short of it is that we should, because the more data and information we have, the better it will be in terms of leading to hopefully guiding her through the pregnancy in a safe and substantial way. My hope is that we eventually will have enough data out there to determine if that's the right thing to do or the wrong thing to do. We know it's not the wrong thing. We know more data is more data, but oftentimes what I even for cardiologists, we always hone in on, is this going to lead to mortality benefit? It doesn't necessarily have to just be, it's going to, or yes, it will lead to mortality benefit, it will not lead to mortality benefit. It makes common sense that if you do a stress test, do an echo, do an ECG before a woman who is high risk, again, has high cardiometabolic risk factors, proceeds with a pregnancy, and they pass that with flying colors, the likelihood of them having a complication is much lower, and we know that they have good cardiac reserve. So I think in these situations, we just have to go back to the common sense of it all. I'm hopeful that we will have more actual clear guidelines in the next coming years as to what we should be doing and how we should be risk stratifying these patients, even including women that are undergoing in vitro fertilization and other fertility measures. There's no guidance out there as to how to best risk stratify them, but they kind of fall under that same high risk category. So I do believe we're going to have more guidance on that in the next coming years. But for right now, I think what you're doing is highly suggested and appropriate, and you should continue with it.
Thank you.
Well, okay, we are past time, but I really appreciate all these questions and comments. And I wanted to thank Dr. Bond for her wonderful talk, and thank everyone for attending, and hope you have a great rest of your Monday.